Hi, this is Dr. Paul Sachs, and welcome to the first of the HIV quarterly briefs of 2023. Delighted to be joined today by Dr. Renslow Shearer from the University of Chicago, where he is professor of medicine. Renslow, welcome.
Thanks, Paul.
All right. So let's start off with the big meeting of the year, which of course was the Conference on Retroviruses and Opportunistic Infections. And we actually returned to an in-person CROI for the first time since 2019, because after all, it was CROI 2020 that occurred right after the pandemic hit. Why don't you start us off by telling us what was presented on HIV prevention?
Yeah, I think one of the interesting pieces of follow-up, a little more of a thorough look at the so-called Levy syndrome, the long-acting early viral inhibition that has been shown to occur with the wonderful use of long-acting cabotegravir as a preventive agent, with quite spectacular results as we've seen from the 083 and the 084 studies. And yet this vexing, very small, so infrequent episode. So they described in a pooled analysis the 6 instances where even when somebody is effectively on therapy, has taken their oral dosing, has not missed any intramuscular injections, they still have breakthrough infections. And it's very difficult to diagnose. So there's a tendency for low-level viremia in the range of 20 to 100 copies or fewer. There can be recurrence of aviremia then following that testing. And so it can be very difficult to pick up.
Yeah. I mean, it's a challenge, huge challenge clinically. One of the reassuring things, every cloud is silver lining, is that it hardly ever happens. I thought it was interesting that one of your colleagues presented a case in clinical practice where it happened, but it is not common. Certainly, I mean, we don't, first of all, have that many people on cabotegravir for PrEP yet, and second is, we haven't seen it yet. So not going to happen a lot. What about more traditional PrEP?
I'll just say it's not a deal breaker. It's very important that it shouldn't diminish the luster of having a big toolbox for prevention. And that was sort of the other study that I thought of when I thought of prevention studies, was a very interesting analysis by Jeannie Marazzo looking at 6,000 women in sub-Saharan Africa enrolled in a variety of demonstration projects in 7 different countries. And in about a third of them, they had good adherence data. And so just analyzing what's going on with women in sub-Saharan Africa, where oral pre-exposure prophylaxis has a little bit of a shakier reputation, particularly among younger women. And they did find, again, the same reinforcement that if you're over age 26, you were much more likely to be adherent than if you were under age 18. But the interesting thing was that about a half of the women, almost half, had really either excellent daily adherence or adherence at 4 pills per week or above, which we know in men who have sex with men and transgender women has been associated with excellent control.
Yeah, no, I totally agree. So the overall impression I got from PrEP studies at CROI this year was that both long-acting injectable and our oral options are really effective, and that really we shouldn't let things like this LEVI syndrome or Levi syndrome, whatever they want to call it, dissuade us from using them.
Well, what caught your attention in the prevention space, Paul?
Well, I can't resist bringing up every ID doctor's favorite antibiotic, which is doxycycline. And why even discuss that? Well, we heard in Montreal from a study of doxycycline post-exposure prophylaxis for trans women and men who have sex with men, that in that study, which was done in the United States, the STI incidence for bacterial infections was reduced, not just for chlamydia and syphilis, but also significantly reduced for gonorrhea, something not seen before in the Ibergay study. Well, none other than Jean-Michel Malina himself, the sort of reigning king of STI prevention in France, he presented a new study called DoxyVac. And DoxyVac included that same patient population of men who have sex with men on pre-exposure prophylaxis, and they had been followed now for a while. And They had a history of bacterial STIs, so it was a group with considerable exposure. And then they did 2 interventions and 2 randomizations. One was to doxycycline post-exposure prophylaxis, and the other was to the meningococcal B vaccine. And the results were fascinating. 700 people enrolled, and there was such a significant reduction in chlamydia trachomatis, in syphilis, and even in gonorrhea that a data safety monitoring board stopped the study early. So that's good news. Additional good news is that meningococcal B vaccine seemed to be protective against gonorrhea. So, chalk up another positive study, favorable study of doxycycline PEP in this patient population. By contrast, a large study done in Kenya in cis women at high risk for STIs. These are women enrolled in a PrEP study, randomizing them to doxycycline post-exposure prophylaxis or no PEP. It's an open label study, standard of care, found actually no significant reduction in bacterial STIs. And it's really not clear why it didn't work in this population. Both groups were at high risk for STIs. Both groups, based on pharmacologic modeling, should be protected, and yet it seems only to be working in this population of MSM trans women. What did you think of these data?
Well, I was struck, as you say, there was a beautiful PK study in a small number of men and women, but it showed exactly what you said, that the pharmacologic support for efficacy of doxycycline in women at risk seemed to be every bit as good as the support for its use in men of sex with men and transgender women. And yet there was this failure, and we've seen this before. And so I think there's more data still to come for the doxy-PrEP in women. I also thought, what a wonderful thing to have confirmation of this association with the Men B vaccine, because that's in some ways a no-brainer. It's like a very reasonable intervention for all men of sex with men at risk in meningococcal B infection, and it's a twofer. You get to 2 pathogens for price of 1. So I think all HIV clinicians should take that seriously in a high-risk STI population.
Oh, so you're ready to put it in the guidelines?
Absolutely. I think it belongs in the guidelines.
Well, let me put you on the spot again then. Doxycycline PEP for MSM and trans women is not in the guidelines yet. Would you recommend it?
Well, I certainly would lean towards it. I'll tell you, I'd like to see a little more population analysis. The problem is that it's going to be difficult to answer the question we all have, which is, what's the impact in this population of the long-term doxycycline use? So
one area that you brought up already was this whole idea of resistance with this strategy. And going back now to the DoxyPEP study from the summer in Montreal's meeting, that group of investigators led by Annie Lutkemeyer, I always like saying her last name, she and her colleagues looked at antimicrobial resistance among participants and a subset of participants, looking specifically at Neisseria gonorrhea, the commensal Neisseria species, because remember, especially our oropharynx has lots of non-gonorrhea and non-meningitidous Neisseria species, as well as Staph aureus. And at least the short-term results were reassuring. They did not see evidence of a lot of evolution resistance. All right, so let's switch away from doxycycline. So long, doxycycline, but you're still every ID doctor's favorite antibiotic. I would like to just bring up this large cohort study called RESPOND. This group has given us analyses before, over 30,000 people with HIV. And what I thought was interesting, point number 1, was that the mortality has declined even since 2012. So that's one aspect of it. And the second aspect of it was that they looked at the cause-specific mortality. And number 1, by quite a bit, was non-AIDS defining malignancies. So, twice as common as AIDS, more than twice as common as cardiovascular disease. It's really quite striking. And when I saw this information, it really resonated with our clinical experience.
My attention was caught also by a publication that coincided with retrovirus and also was released last fall at ID Week. That was the 10-year follow-up of the START study. And partly it just shows you if you stick with a large, well-designed cohort, you continue to learn things. And it was that there still is this gap of about 100 T cells that is not recovered, that those who started drugs later, they did very well with virologic control, but they all never quite recovered their CD4 cells. And both the composite endpoint and the serious non-AIDS events and death endpoints were still different at 10 years. So sort of the lingering effects, they said the risk of serious events was substantially diminished after 10 years when we treated everybody, but the difference in the risk didn't go away. There were benefits to early therapy long afterwards, after 10 years. Well, there was another study like that, Paul, I wanted to share with you. This was the long-term follow-up, 6 years of follow-up from the Kaiser Permanente Foundation, which has done such nice work in sort of looking over long periods of time at large groups of people, sort of real-world impact. And this was an analysis of same-day rapid start compared to standard of care start. And they found in the short term, there were equal numbers of good virologic control in the group, around 80% for all comers. But what they saw overall was actually that there wasn't this immediate benefit or long-term benefit in terms of virologic control or superiority of same-day start, of superiority with virologic control, with retention in care, or adherence to therapy. Now, using a cohort study to answer that question over 6 years is fraught, right? We know there's all kinds of reasons people are in and out, but I think there was a good discussion at Glasgow with the British HIV guidelines on where do we really stand with rapid same-day start, and they were very common sense about it, that it's great if you can do it and you have your social supports in place, but rapid start means in the first week or two, or as soon as you can get it all together to do it for your patient. And that's the benefit we just saw in the START study.
Yeah, approach you mentioned, the strategy is totally reasonable. Start them when you can. Don't feel like you have to do it now. There's just they want to be on treatment too. So, it's like people newly diagnosed with HIV. It's like, why wait? Right. Treatment's so effective and so simple now, they can go ahead.
I want to cite this very modest little 51 patient trial in Spain that approached a group of HIV positive, HIV negative people and said, we're going to give everyone 12 weeks of a serious structured exercise program that's manageable. We'll fit it into people's schedules with resistance and endurance and balance training and yada, yada. And they were able to show reversal of the pre-frailty stage. So fewer people entering or being in that pre-frail stage. And then for those who had arrived at frailty, substantial reversal. And it was about equal in the HIV negative and the HIV positive group. Everything that is a complication of the chronic inflammaging immune activation with HIV, the thinning of bones, the loss of musculature, the poorer cardiovascular health, the depression or HIV-associated neurologic deficits, they're all better when people exercise regularly. And it's this win-win-win-win-win if you can just get people to mobilize and become active.
Let's talk about weight. I'm going to bring up the AMPATH study, which basically looked at weight gain among participants in Kenya switching to dolutegravir-based HIV regimens. And what the study showed was fascinating. It showed, not surprisingly, that people who switch do gain weight. And if you looked at their baseline nucleoside, most of that weight gain in the women was coming from women switching off efavirenz. In fact, in both the women and the men, it was the switch off of efavirenz that led to this sharp increase in weight. And it was not observed in individuals who had been on baseline nevirapine. So once again, we're seeing that it's almost as important, or maybe just as important, to know what the baseline regimen is as to what you're switching to. And this is one of several lines of evidence we've had that efavirenz is probably doing something to suppress weight. So we don't know what it is, but it's something that's in particular seen when people are on TDF at baseline. So the combination of TDF, FTC, and efavirenz is a weight suppressive regimen, and switching off that, especially to one that has dolutegravir or bictegravir and does not contain TDF, is going to lead to the greatest weight gain. And that's true if you're switching to bictegravir FDC TAF, dolutegravir FDC TAF, or dolutegravir lamivudine. So very interesting study. All right, let's go to another switch study. This one has nothing to do with weight, you'll be glad to hear. This one is about antiviral activity of second-line regimens. It's called D2EFT. I think that's how you say it rather than D2EFT, but it's D2EFT. And the D2EFT study really is asking the question of what's the best second-line regimen. And we've looked at these studies now for years because there are a bunch of people, especially in sub-Saharan Africa, who are on failing regimens with a nucleoside, 2 nucleosides, and a non-nucleoside. But this study evaluated a third strategy, which is dolutegravir plus darunavir-ritonavir. Well, the good news is that dolutegravir plus 2 nucleosides, the TLD that's taking over most of the world, was basically non-inferior to the standard of care of darunavir-ritonavir plus 2 nucleosides. But really, I think most interestingly about this study was that the 2 new drug classes, the dolutegravir plus darunavir-ritonavir, was for the very first time statistically significantly better than a recycled nucleosides plus a boosted protease inhibitor. They did mention that both of the dolutegravir regimens did lead to more weight gain than the non-dolutegravir regimens. What did you think of the study?
Well, I wasn't surprised to see that it was actually superior, as you say, to the boosted darunavir with 2 nukes. That I think that was what you would anticipate. There's not a pharmacologic interaction or anything else to undo that. And I also thought it was interesting when they extended the stage 2 portion of the study after Nadia had been published and just said, we can just use the co-formulated TLD. That is so seductive because it's available, it's co-formulated, it's easier to take. It's not 2 pills, rather 1 pill. So I'm actually sympathetic to the continued use of that regimen after the surprising results from Nadia. Mm-hmm. But to have another option, another nuke-sparing option at the ready, I think is really quite important. So I thought this was another invaluable study on that large group of people who failed their first NNRTIs.
Tell us about the SOLAR study.
So this was a head-to-head comparison in a 2-to-2 to 1 randomization of folks who had been on bictegravir, TAF, and FTC, either staying on it in the one group or switching to one of 2 different regimens. And that's an oral lead-in for cabotegravir, rilpivirine, followed by the long-acting injectable, or just going straight to injection with a 12-month follow-up. 90% and 93% respectively were controlled. So really, I think another wonderful option in our toolbox. Also, not surprisingly, there were a few patients who had confirmed virologic failure on the cabotegravir rilpivirine arm in whom resistance developed. In the long-acting arm, so that was 3 out of 447 people. So we're seeing less than 1% with virologic failure and a risk of integrase and NNRTI resistance among those individuals.
Yeah, I mean, it was a very clinically relevant study because there's such a gigantic number of people on bictegravir FDC TAF.
So there was one other very useful study, I thought, from the Owen Clinic at UCSD, Paul, on the same subject of how do we know who might be at risk to be among those very few people who have virologic failure or breakthrough. So this was an analysis of the folks who switched over in the Owen Clinic into long-acting cabotegravir, and it was like 144 patients overall, and they did find that those who had blips were more likely to have blips on long-acting cabotegravir. So I'm not sure what to do with this. I think it's really an important observation. So I'm glad to be the one presenting it because I'm going to throw it back to you, Paul, and say, I know you're very on to blips as a sign of maybe bad things to come. But in this particular analysis, I find it difficult to know what to do except to follow these people longer term.
I think we now know that people with blips who are on high resistance barrier regimens typically do fine without intensification or changing their regimen. but what we don't know is whether that's the case with people going on long-acting capropivirine. And so what I would say is that if you're made nervous by blips, then you're going to be made more nervous by blips after switching to capropivirine. That's kind of my take home. We are going to stay in the long-acting injectable space very, very briefly to just say that the Ward 86 shared with us additional data about the strategy of using capropivirine in people who really are not kind of the ideal candidates. As everybody now must know, this is a safety net population in San Francisco. And I will just say that the most important part of this presentation are the people who are viremic at baseline. And that was 57 out of the 133 they presented. And in this 57 who are not on oral ART, essentially because they can't be on it, they had only 2 of the 57 experience virologic failure. And importantly, Monica Gandhi, who presented it, said that they were still not on oral ART even after going through treatment failure with this regimen. So it's not for lack of trying. I feel like this strategy could be a really transformative for that subset of people, rare though they are, who cannot take oral ART for whatever reason. And I would just wish that we could see data from at least one other center or a multi-center study enrolling, 50 to 100 other people, so that we just know, is it something special about this clinical program, very heavily resourced in San Francisco, or is this really a regimen that we should turn to now in order to save someone's life? Another study that is in the long-acting category is this really a proof of principle more than something that's going to be available to you right now, and that's lenacapavir with 2 broadly neutralizing antibodies. So the patient population is people who have had a very high baseline CD4 cell count. So they're people who, have never had advanced disease, people who've been virologically suppressed for a long time. That's another thing that you have to remember, a good long time, and no history of treatment failure. And then they're random. Then they undergo a screening test where they check their HIV DNA to see if they have susceptibility to these 2 broadly neutralizing antibodies. And it's true, in this small number of people, 90% maintained viral suppression. There was one person who developed rebound, and it's unknown why. The person had a virus that was susceptible to the capsid inhibitor and susceptible to the bNAbs. And the other important caveat is that in this screening procedure to find out susceptibility, less than half of them had sensitivity to both the bNAbs. So we have a proof of principle that an every 6-month injectable treatment is feasible, but what we don't have is something that really is broadly applicable now.
Well, I completely agree, Paul. My imagination was captured by this one. Every 6 months, just in a simple injection. It sounded too good to be true. And like you say, it was. I also was excited by bNAbs making it into real people and showing real results, because we've been working with them for quite a while. You're right, there's still lots of barriers, but I thought this was a promising start.
Yes, I'm generally an optimist by nature, but about bNAbs, I'm sort of remain more of a pessimist.
So in that same light, I'll talk about another switch study also involving bictegravir, TAF and TAF. This was the intended registrational trial with a switch to doravirine and the islatravir at the dose of 0.75 milligrams, which has since then been a dose they've decided not to move forward with, and we'll talk about that. But just the idea of switching from one oral to another, in this case, doravirine, islatravir, was highly successful. It was non-inferior. 93 and 94% of people were controlled in both arms with very few adverse events. It was well tolerated. There was very little weight gain overall, only about 1/4 kilo in the doravirine islatravir group compared to 1/2 kilo in the BF-TAF group, which were not significant differences. And they did see this change in total lymphocyte count and CD4 cell lymphocyte counts that's led to the cessation of that particular dose of islatravir. But I think just as a proof of concept to another 2-drug regimen that has some attractive features, it's in a different class. It's doravirine is the NNRTI that's not efavirenz, that's not associated with CNS side effects and the other attributes with weight retention, weight loss, for example. So I think I thought this was a very useful study in spite of its limit.
Yeah, I mean, we clearly the doravirine islatravir single pill is going to go forward at the reduced dose, the 0.25 milligram dose. The real question would be whether it has any advantages over existing 3-drug and 2-drug strategies. So, we already have dolutegravir lamivudine and dolutegravir rilpivirine and cabotegravir rilpivirine. And, is this going to be better in some way? We'll see. I think probably most exciting is still in phase 2 is the once weekly islatravir or lenacapavir strategy, but no data presented on that of any significance. So finish us off with a coverage of a really serious opportunistic infection, one that's not on the OI criteria for AIDS diagnosis, but probably should be.
Yeah, this was a study that Chloe Orkin pulled together the reported cases of the severe monkeypox, Mpox, in people with advanced HIV, and ended up with 258 cases. And we submitted 2 of those cases and actually saw a third, all in the space of about 4 months from September to December of last fall. And they were all with the same characteristics, which was very severe initial presentation with multiple sites, with very low T cells, with a very high mortality, for most of the mortalities being with T cells less than 100 or with active viremia. So again, either untreated or advanced disease, with coalescing lesions, with lesions that were unresolved, that was a lack of response to tecovirimat, and oftentimes a lack of response to tecovirimat, vaccinia immune globulin, and then even the addition of cidofovir. And this led to the CDC huddling with clinicians during the fall and then making very concrete recommendations for basically more aggressive initial approach to worrying about it, be very concerned about making the diagnosis accurately, aggressive use of the vaccine, and then using 2 doses in everybody with the vaccine. I think it's an awkward story because it was occurring at a time when Mpox itself was declining, which is still true. It reminded me, Paul, of the early days of HIV, where everything you did was not useful. Patients didn't respond and got worse and worse and died of really severe complications. So you sort of throw up your hands and do everything you can. I would say aggressive antiviral therapy, thinking about early use of cidofovir concomitantly and vaccinia IVIG for everybody. But my hope is we're not just going to see as much of this anymore, because it's really a dreadful condition.
I hope you're right. It really is terrifying. And if you haven't seen the full report, it's in Lancet and well worth reviewing. So Dr. Shearer, Renslow, this has been a great discussion. Thank you so much for joining me in this first of 2023 quarterly briefs. And thanks to all of you for listening.
Well, I'm honored to be invited, Paul. Thanks very much. It was fun.